I'm Anne Duggan. I'm Clinical Director of Healthcare Variation, the Australian Commission on Safety and Quality in Healthcare. I want to introduce you to healthcare variation, a topic which I think is incredibly important if we want to have a healthcare system that works best for everyone. I want to start by telling you a story of, let's call him AM. He was a young man who presented to my outpatient clinic a number of years ago. He was critically ill, the effects of chronic diarrhoea and inflammation. Desperately ill. He was a security guard and he'd taken to carrying an extra pair of pants to work in case he had an accident. He said he didn't know how to access an earlier appointment with his GP or with the outpatient clinic, so he just soldiered on. By the time I saw him, it was too late to do anything medically. He needed an operation to remove his bowel. Unfortunately, he survived that. AM's story is a powerful example of healthcare variation, when care varies from what we know is best practice. That's, in his case, early intervention when disease becomes active, and ideally maintenance of remission so that the disease does not flare up. Now, the critical question is, if you looked at patients like AM across Australia, would he be an isolated standout, or would you find other patients whose care varied from best practice, and that care was not because of their preference or need? Because that would be unwarranted variation. That's what we really want to focus on. Now, in the case of AM, you notice that it was not because he didn't know he needed medical, not because there was no healthcare system near where he lived or doctors to provide the care he needed. His events occurred because he didn't know how to access the healthcare system. But more importantly, the healthcare system didn't make it easy for him to access it. It wasn't of his choosing. We were fairly devastated by what happened to AM. We were determined to rethink our system to ensure it didn't happen to any other patients. It was too late to help AM, but we had an obligation to fix our system so it didn't happen to others. We rejigged our service and used funding that we had for another purpose to fund a liaison nurse whose job it was to help patients with similar problems. Patients could directly access this nurse by phone. That way, we could ensure they would get appropriate triage. They would be seeing us when they needed it, not when it was their turn, according to the predefined booking. They could get rapid advice, they could get support, they could get urgent review. As you can see from the case of AM, examining healthcare variation is critical to providing quality care. We have to address the causes of unwarranted variation because it has huge benefits for patients. And of course for us as clinicians, because we all want to provide the best possible care to every patient and every time. For today's talk, I want to dig deeper into why healthcare variation matters. I want to explain the difference between warranted and unwarranted healthcare variation. I want to emphasise how data about healthcare variation is pivotal to starting that journey to improve healthcare outcomes. Most importantly, of course, tell you what you can do in your sphere of influence to contribute to making the healthcare system better. Drive out unwanted variation. So let's think about healthcare variation. We've made massive gains in both life expectancy and the quality of life for thousands of people through new ways to diagnose conditions, new ways to treat conditions, the development of new medications and new surgical techniques. Despite these marked improvements, we're still seeing marked variation in the provision of best care. You see it across countries, within countries, between cultural groups, and according to insurance status. There's inequity of access and a failure to deliver services fairly. We see indication creep, the use of technology and medicines beyond the evidence base, bringing risks of harm and sometimes unknown benefits. We see gaps in the use of evidence. We at times know the evidence, but it's not being practiced, demonstrating the need for clinical care standards and those standards to be known by everyone, the system, clinicians, consumers. And we know at times we have inadequate system supports. We need changes in the way we design our healthcare systems, better provide the care that's needed, to provide better training and appropriate training of the right workforce and the right financial incentives and disincentives to promote best care, to stop inappropriate care. Now, some variation is warranted. Healthcare variation can be the hallmark of a very sophisticated healthcare system that is reflecting the differences in patient preferences or needs. So you will see variation because of differences in healthcare needs due to age, gender, risk factors, and of course preference. Take, for example, osteoarthritis. It's much more common as we get older. So you'd expect much more healthcare related to osteoarthritis in older populations. Breast cancer, much more common in women than men. So you'd see a gender difference in the use of investigations and chemotherapy for breast cancer among women. Likewise, when you see groups of people with risk factors for disease, then you see more treatment of that disease in that group. And probably the perfect example is smoking and lung cancer. Smoking is a powerful driver of lung cancer, and so you would expect to see more treatment in smokers. But of course, there's preference that may drive variation. If you're overweight and have osteoarthritis of the knees, then you may choose to do exercise and lose weight because there's evidence that that makes a substantial difference to the pain in your knees, and for many people obviates the need for surgery. Other people may choose to go to surgery. So that's warranted variation. That's a great, sophisticated healthcare system. But there's unwarranted variation. And unwarranted variation is where the variation can't be explained by either patient need or preference, and it's typically an indication that something needs to change, be it in the system, be it among clinicians and the way they work, or consumers and how they use the healthcare system. The system might not be efficient as it should be, or it may not be effective in providing equity of resource allocation, or the way it uses technology may have problems. It may not be using the latest or providing the latest technology, or it may be allowing that technology to be used beyond the evidence base or its benefits. Clinicians. There may not be an appropriate distribution of clinicians, and we see that in Australia, the difference between metropolitan, rural and remote areas. The skill mix may be wrong. If you're a diabetic, you need not only to have access to a diabetologist, but many other people to look after your feet, your eyes, etc. The skill mix is also important. But of course, having people there is not enough. We need to have clinicians using the best evidence. So variation can quite clearly occur when people aren't applying the evidence. Consumers can clearly have too little or too much access. Access can vary due to geographical differences, which I just mentioned. Your access in remote Australia is far different to your access in metropolitan areas. Financial barriers are increasingly a cause for unwarranted variation. Consumers can also not be aware of the risks and benefits of treatments and have poor choices. And for that reason, we really do promote the idea of consumers partnering in their care, being informed of the risks and benefits, the options, and making informed decisions so that patients are getting the best care for them. Well, why does it matter? I think you already have an idea as to why it matters, but I think one of the best and the first studies to really look at healthcare variation was a paper published by Glover 80 years ago. Glover study is fantastic for looking at variation at a large scale. Looking at the data at a large scale allows you to see things that you don't from your isolated perspective. And 80 years ago, Glover looked at tonsillectomy rates among school children in school districts across England and Wales. He himself was surprised at the results. He made three, I think, very pertinent observations. One, if you don't look, you won't notice what's really going on. Two, if you don't look, you won't see the harm that is going on. Now, the third thing that Glover said was, why does variation occur? He couldn't explain it, and he said it defies explanation, save for the difference in medical opinion about the indications for surgery. We've moved on from that. We know much more. Before we move on, let me quote one other thing that Glover said, that the mortality directly due to tonsillectomy was greater than is usually appreciated. His study told him something that he wouldn't have known from his own practice. In the modern era, we've moved on to atlases, and the first group to do that was the Dartmouth group in the USA. And you can see just from that map how powerful atlases are at describing the healthcare variation that Glover was talking about. Here you can see quite almost a mosaic of differences that don't make immediate sense and call for inquiry as to what is going on. Well, in 2015, Australia started doing atlases of healthcare variation. This provided us with the data to look at common conditions and their management and to see what was going on and how much variation occurring. It enabled us, it provided the platform for healthcare reform. Let me give you just one example. As I said, osteoarthritis of the knee is very common as we age. It affects a large proportion of people. So if we don't get the management right, it affects a lot of people. If people don't get the care they need, they're harmed. If they get care that they don't need, they get potentially exposed to harm without benefits. So it's incredibly important that we get it right. So we looked at arthroscopy and we also looked at knee replacement. And in each case we identified the variation, we investigated, we addressed it. So in the case of arthroscopy, which is that keyhole surgery into the knee with a camera on that telescope that allows you to look inside the knee, we looked at the data in the first atlas on how much was going on in Australia. Now, one of the key reasons for looking at that was as early as 2002, the evidence from randomised controlled trials was really questioning the benefit of arthroscopy in many clinical scenarios. and clinicians were beginning to get concerned about its use outside best practice. Now, what you can see, however, on the left-hand side, if you follow along the x-axis, the horizontal line, that's 1995 to 2017. And if you look at the vertical axis, which measures the number of MBS-funded surgery, that's a medical benefit scheme-funded surgery, there was a continual rise in arthroscopy beyond 2002 and only a recent fall. Surgery skyrocketed, really, for 10 years after the evidence came out showing it didn't benefit the majority of people with osteoarthritis of the knee. So we looked at arthroscopy, we mapped it, we found that there were 33,000 admissions for knee arthroscopy in 2012-13. We found marked variation with particularly high rates in South Australia. So on the right-hand side, you can see Australia, and we've broken it up into regions called SA3, which are the national system for describing the distribution of the population. And then we've standardised the data so it's valid comparison. We mapped by where people live. And so if you look at that, you can see there's a marked variation. High rates in South Australia, but in other parts of the country, very low rates. It was a 7-fold variation. 7 times different between the lowest and the highest. So what do? We fed the data back to states and territories. We fed the data back to the local health services, and we provided the data to the Commonwealth, who are the funders of the MBS, and they revised the funding of knee arthroscopy. We identified in discussions with clinicians and consumers that there was a gap in the guidance to support best practice, and so we developed a clinical care standard to fill that gap. As a product of that feedback and that activity in developing and promulgating a standard used to help clinicians, to help health services and to help consumers to provide and receive best care, the rate of knee arthroscopy in Australia has halved since 2012. In 2012, the rate was over 500 per 100,000. 2019, it was less than 250 100,000. Hope it will continue to fall until it reflects the appropriate use of knee arthroscopy. And what can you do? It's important to support everybody in the system to reduce unwarranted variation. And everyone has a role. Go to our website, because on our website you can find a multitude of resources. You can find our atlases, you can explore our atlases and look at the interventions that we've mapped. And we've got another atlas coming out this year, which will also be on our website. We've developed a user guide, and that is a step-by-step guide to help you in the process of identifying and addressing variation. And in that guide, we've also included examples from clinical groups who've done a great job in their area of expertise to reduce variation. They're very happy to share their examples. That's there for you to use. You can also access the clinical care standards so you know what best practice is, and you can use those resources to promote best practice. I think all of us clinicians have a responsibility to measure our outcomes against our peers, against relevant standards, and where they're available, against outcome data from registries. I urge you, go to the website, download the user guide, start looking and discovering what's going on in your area. But before you do that, join me in the second of our series on the Atlas, where we look in greater detail at what we've been doing in the Atlas. And that's beginning to be followed question and answer session. Thank you.